and I'm going to screen my share, screen my share. Okay, can you all hear me and see my PowerPoint presentation?
Yes, we can.
Excellent. Okay. All right. So what we're going to do today, learn and identify the layers of meninges, nervous tissue and bony structures within and immediately surrounding the spine. We're going to identify the structures comprising the knee and the shoulder specifically, because they're more indicative of just MSK joints. Okay. So we've got a different type of joint. We can't go through all the joints in the body, so we're going to pinpoint the knee, or we're going to choose the knee and the shoulder and the structures that are indicative of those. We're going to have a look at the specific structures in these joints and have a look and see how they're displayed in the routine planes. So there's our vertebral column. We should all know that that's a vertebral column. It's got vertebrae, it's got spinal processes, it's got all the little bits and bobs around it. And I believe Peter, if he hasn't already, will take you through mainly the bony structures that we see on CT. We see bony structures on MRI, but not very well. So MRI gives us a much better indication of the nervous tissues and the soft tissue structures in and around those bony structures, okay? So we're going to concentrate more on the meninges, the layers of the meninges, the different layers, the different nervous tissue that's in and outside the meninges that we see on the images. Okay, so bony structures, I guess we can have a look at the spinous process, we know, inferior unarticular processes, hopefully you know, posterior tubercle of transverse processes, anterior tubercle of transverse processes. And we've also got the foramen transversum, or the transverse foramen, which has the vertebral artery runs through it. Okay, so this is more indicative of a cervical spine vertebrae. We've got the vertebral body, we know. We've got the disc annulus, all right? So we've got the disc in between that when we jump up and down, that cushions the impact. And we've got the nucleus propulsus, which is the middle of the disc that supports that impact. We've also got the spine. We've also got the grey and the white matter that we can see in MRI images. We can distinguish between the grey and the white matter, the dorsal nerve root and the ventral nerve root. Okay, so dorsal's at the back, like a dorsal fin of a fish. The ventral nerve root is at the front. Okay, they combine at the ganglion, nerve root ganglion, and of course intraforaminal space, nervous space, and the spinal nerve coming out. Okay, we'll intervertebral foramen. So we've got, as I mentioned, we're going to cover the different types of layers of the cord that we will see. Obviously they're very, very small. So if there's pathology in and around them, we'll be able to see what sort of pathology that is, okay, or where that pathology is because of its presentation, which is another lecture I think you guys will probably have. And by that I mean subdural, intradural, extradural bleeding and things like that. You have different presentations on the images. So you have epidural space, and you have the dura mater, and you have subdural space. Okay, so dura mater, we can see there covers pretty much the structures. The structure outside of it is epidural space, epi meaning around, and subdural inside. We've got the arachnoid mater or matter, and we've got the subarachnoid space where we see the CSF. Okay. Then we have the pia mater, which actually the coverings of the brain, or in this case the nervous tissue, and we've got the nervous tissue underneath the pia mater. Okay, so there's our different layers there. And then, of course, we've got the different structures around there that we've pretty much just gone through. There's the spinal ganglion there. So the bones we've just covered. These are the atlas, the atlas and the inferior view of the atlas. Okay, so yeah, we know that's C1. Okay, so we've got the anterior and posterior from inferior, anterior, from superior, and anterior and posterior from inferior. Okay. C4, an example of a cervical vertebrae, the body, the transverse foramen, articular process, lamina at the back, and spinous process. Okay, so if they do a laminectomy, they go from the back. Okay. Superior articular facet, inferior articular facet, the tubercle, posterior, anterior, and the vertebral body. All right. So how does that look on a T2 weighted image of the cervical spine? Okay, we've got the spinal cord. So if we're in the cervical spine, we'll see the spinal cord. Okay, we know the cord goes down to about T12L1. All right. But that does vary depending on the patient that we're scanning. It can move a little bit. And it can also move depending on pathology. So they could have something called a tethered cord, where the cord, during development, the cord gets stuck and it actually doesn't progress through the spine as the spine grows. Okay, so it stays very low. Spinal cord, as I just mentioned, we've got the pia mater, which covers the spinal cord. We've got the subarachnoid space. You can see is bright there because it's a T2, and we're looking at CSF in the subarachnoid space. Then we've got the arachnoid mater, which is just outside the subarachnoid space. Very difficult to pinpoint exactly where these are on this image. Subdural space, and of course the dura mater. Okay, and then we've got the extradura mater and the extradural space around there as well. Okay, so that's the coverings of the brain. We're looking at that's the coverings of the cord that we're looking at. Of course, now we're going to look at the structures around the cord. Okay, so we've got the C1. Okay, we can see the C1 there, the posterior arch of C1 or the atlas. Okay, and then we've got the odontoid process or the axis, the odontoid process of C2 and the posterior arch of C2. Okay, anterior longitudinal ligament, of course, runs along the anterior part of the vertebral column. Okay, or the vertebrae. And then we'll have the posterior longitudinal ligament, which runs the posterior aspect of the vertebral canal. Okay, it's not anterior and posterior to the spinal cord, it's anterior and posterior to the vertebral canal. Okay, a lot of people get those confused. Intervertebral disc, so we've got the disc space there, C4, 5. So we've got 2, 3, 3, 4, and then of course 4, 5. Okay, you know that from x-rays, I don't know why I'm doing that. Okay, so subarachnoid space I've mentioned, and then of course we've got the trachea. We've got the ligamentum flavum. It's a ligament, so it's dark on T2 and T1 structures, okay, and it doesn't have any hydrogen in it. All right, and then of course we've got the spinous process in this case C6. Okay, 2, 3, 4, 5, 6. Spinous process of C6. Okay, so if we move a little bit more laterally, we can see we're starting to come out of the cord. We've got the foramen magnum. Okay, At the base of the skull, we can see the odontoid process a little bit lateral, more lateral. As I say, we're losing a bit of the spinal cord. We're getting a little bit of partial voluming along there. We've got the anterior ligament, we've got the posterior ligament. It's a little bit flatter than you'd expect, or than I'd expect. The disc space, and the ligamentum flavum. So we've got all that stuff. Now, as we move a little bit more lateral, we can see that the nerve roots have come out of that spine. So we were looking at the nerve roots before, and we can see how those nerve roots have come out of the cord and they're exiting through the neural exit foramina. Okay, so we'll be able to see in a sagittal plane, we'll be able to see an axial shot or axial slice through those nerve roots. Okay, and sometimes in MR we have recent stages, the last couple of years, there started to be a routine scan where we actually do oblique scans to those nerve roots, so we can see the compression on those nerve roots as they exit, and you can see obviously that dark nerve root in amongst the bright fat in there. Okay, we know even though it's a T2, there might be a little bit of water there, but that's still fat because fat is still bright on a T2. Okay, so we have the pedicle, we have the superior, and we have the inferior articular process to those vertebral bodies. Okay, the joint space, yeah, and we've mentioned the ganglion. So again, we've got the superior and inferior articular space. The joint, the nerve root ganglion, so up there you can see an axial through that nerve as it exits the spine and comes out through the foramen. Okay, and we've got the pedicle there, the back, as we discussed. Okay, so now we've switched from a T2 weighted scan of the cervical spine, we've switched to a T1 weighted scan of a thoracic cord or the thoracic spine. Okay, so it's important to realise that we've still got, in the thoracic spine, we've still got a cord. Okay, we've still got the spinal cord that runs through the thoracic spine. Okay, it's not till the lumbar spine that we start to see that break up, because we'll be imaging below the conus medullaris. So the conus medullaris, or the conus, I mentioned, is about T12L1, and it's the termination of the spinal cord. Okay, so if you can see a spine, if you can see a spinal cord in your images, you're not looking at lumbar spine, you're looking at thoracic spine. Anterior, this anterior longitudinal ligament, and of course we've got the posterior longitudinal ligament. We've got the cortical bone. See, cortical bone is hypointense on all images, again, because it has little, it's so tightly packed, there's little hydrogen protons. Okay, and then of course we've got cancellous bone. We know cancellous bone is bright because of the fat in cancellous bone. Okay, again, we're looking at a T1. T1 has the fat's bright, and T2 the fat's bright in most cases. Excuse me. So the bone is bright. The cancellous bone is bright because there's fat deposits in that cancellous bone. Again, nucleus propulsus and annulus fibrosus. Okay, so we've got the disc space there. Okay, we've got the thoracic spinal cord, epidural fat. So we can see there that if you look at the top of my pointer, you've got the spinal cord, and then you've got the subarachnoid space. This time it's dark because it's a T1 weighted image. And then you've got the epidural fat that's outside the dura mater, okay, or outside the layer of the dura. And of course, we know that's fat because it's bright, okay, and it's not fluid because the CSF is fluid and that's dark. okay? Thoracic spinal cord. We've got interspinal ligaments and we've got ligamentum flavum. Okay, so ligamentum flavum is very important, we know, because that keeps the spinous processes, holds them secure and makes the joint stable. If we lose the ligamentum flavum, the joints become unstable. Okay, and we don't want that in the spinal cord. So we've got a ligamentum flavum that's dark, and we've got interspinal ligaments. They're dark as well because they're ligaments, but you can see the stripy appearance there. That's because they've got fats around them, okay? It's not as dark as the ligamentum flavum. Okay. And of course, we've got the spinous process there. We know the spinous process is posterior to the spinal cord. Pedicle, okay. We've got the vertebral bodies, of course, we've got the discs and we've got the end plates. So we've got the cortex of the vertebral bodies, okay. Same again, same as the cervical spine, we've got the dorsal root ganglion where the dorsal and the ventral nerves, as they combine or meet. Superior inferior articular process, we've got the ligamentum there because we've come a little bit more lateral, and we've come a little bit more lateral there. Okay. Of course, now we've come very lateral and we're into the transverse process. So we're at the side of the vertebrae. And it's important to understand where you are. When you look at that scan, what is that scan? Where is it in the body? And what sort of a slice are you looking at? Obviously, you can't distinguish between left and right, but you should be able to look at that slice and be able to distinguish the different structures. We don't often do a coronal image of the thoracic spine or the lumbar spine or the cervical spine. There's only few indications where we do coronal imaging, and that's to see the nerve roots as they exit the cord. Okay, so if there's a condition known as neurofibromatosis, where there's tumours that grow on these nerve roots. And because it's very difficult to get axial scans all the way down, fine slice axial scans all the way down the spine, I guess it's not difficult, it's more time consuming. That could take up to 20 minutes, 25 minutes just to get stacks of axial scans all the way through the spine, high enough resolution to see those little nerve deposits. So instead, what we do is we do coronal imaging through the spine in one weighting. So we just see those nerve roots coming off the spinal cord. Okay, and obviously you can see the spinal cord there in the middle. You can see the dark spinal cord in the bright CSF. So we know that's a T2 weighted scan. Okay, and again, I guess another way of importance of recognizing that is recognizing the structures inside it, deciding on their intensity or assessing their intensity, and of course working out the weighting. So again, we've got the meninges. Okay, very similar to what we said before. And please relate that. Feel free to relate that back to the diagram that at the start that we went through at the start. So we've got the trachea, we've got all the stuff around the esophagus, the vertebral body. We've got the cervical nerve and the spinous process. Okay. We can see those nerve roots. We can see the dorsal and the ventral nerve roots coming off, and we'd just be able to see the ganglion. Okay, before we lose the level of the nerve and it travels down through the canal. Zygoapophyseal joints, so we know that's the joints between the superior and inferior articular process. Epidural fat, we can see there is the bright signal. Okay. Of course, anterior and posterior longitudinal ligaments. We're also looking at very, very low down the thoracic spine. So we've got nerve root bundles, which is below the cauda equina. We travel down into the lumbar spine. Fecal sacs filled with CSF is the red star. Green star is the ligamentum flavum. Okay, so the ligamentum flavum is at the back, okay, of that green star where it's dark. Okay, that green star is actually, and I'm gonna repost this. That green star is actually epidural fat. Okay, but it adds some stability to the spine. And of course, the blue thing here, this shows a really good image of the blue arrows is the posterior ligament. Okay, so of course we've got a herniated nuclear propulsus, a herniated disc, and that disc has pushed out the posterior longitudinal ligament. So you can see it there on the image. Okay, convenient for us, but very sore for the patient. You can also see that this is a T2 weighted scan, and the disc here is very bright. That means it's wet fluid and it's able to take the cushioning from the vertebrae, okay, which is good. Out here, it's not so wet, it's dry. And certainly down here, where there's injury, it's lost, it's called desiccated. So it's become dry and it's lost its compression, okay? And as such, as I say, it's dry and it's herniated the disc out into the spinal cord, which is going to cause a lot of pain. So again, you've got the structures, you've got the conus medullaris, and then you've got the cauda equina, the ligaments, filum terminale, which is just like an anchor to the cord, okay, or to the thoracic cord. And then you've got many of the structures that you saw earlier, okay, in the thoracic spine. Same again, okay, so you can see there the cauda equina, which I think is Latin or perhaps Greek for horsehair, and you can see there it's got its appearance there like a horse tail or something. Okay, so we've got the spines all bunched together and then it's come apart and you've got the individual nerve fibers there. All right, you've still got the discs, anterior, posterior, and you've got the filum terminale there, I think I've mentioned, where it just anchors the spine down, ligaments, and the epidural fat. Ligaments. Again, pretty much the same as before. We count down, so L5, L4, L3, L2, L1, count up. Ligaments, nerve roots. We've got the pedicle, okay. Inferior and superior articular process, zygoapophyseal joint there. And then we've come laterally. And we see, of course, we see the pedicle and the nerve roots. This is just a diagram to remind you of the different structures in and around the spinal cord. Okay, so one is the nucleus propulsus. I've mentioned annulus fibrosus around the disc. We've got the cauda equina. Okay, so we've got the fecal sac. And we've got the cauda equina inside the fecal sac. And we know that that swims in CSF. So we know the CSF is in that thecal sac. Of course, we've got the facet joints, zygoapophyseal joints. We mentioned the ligament. Epidural space, so around the thecal sac, okay, filled with vessels and fat. Intervertebral foramen, so we've got the intervertebral foramen where the nerves join and then they come out through the intervertebral foramen. And there we have it on the pictures, okay, or on the images, the MRI images. So, of course, we don't see that cord anymore. We see the chorda equina. We see the individual filaments. Okay, we see the ligamentum flavum at the back, dark. And the joint space, the intervertebral foramens. We've got the psoas muscle around here. So again, when you look at this image, we do expect you, or you should be able to look at the level and see in so much as that's the lumbar spine. This is an image of the lumbar spine, okay, right, as opposed to the thoracic or the cervical spine. Okay, you should know, you won't be expected to know, no one can be expected to know exactly where that is in the lumbar spine, but you will be expected to know that that is the lumbar spine with the chorda equina. Okay, and those nerves coming out, eventually making it through into the intervertebral foramen, through into the nerve roots. Okay, so any questions on the nerves before I move on to the joints? No. Okay. So we move on. We've got, we're going to talk about the structures of the knee. To remind you, there's the structures there, mainly the ligaments, the cartilage, and MRI has a valuable tool to offer, is a valuable tool to offer, in so much as it demonstrates mechanical damage. So we have two sets of protocols generally. Two basic sets of protocols in MRI. One set of protocols is for the mechanical damage, which is basically looking at the structures that you can see there. And the other set of protocols that we use is tumour and infection protocols. Okay. So of course we do a different set of sequences that looks at tumour and infection processes in and around the joints and the rest of the body. But we differentiate those two protocols. And in this case, obviously, we're going to be looking at the structures. So we're going to be looking at the mechanical structures. So we call it internal derangement of the knee. So you can see there the different structures in a sagittal scan, a midline sagittal. Of course, you've got the patella, the femur, and the tibia. Posterior cruciate is thick and dark, okay? Anterior cruciate ligament is not as thick, but it's still obviously very, very dark. Again, it's got some fibers inside it that we'll see, but it's generally very dark. Because it's made of collagen, it's got no hydrogen protons. The gastrocnemius muscle, we'll see that better on the axial scans. And the patella tendon and the quadriceps muscle and tendon. And the cartilage, we see the cartilage quite well as well, but we're going to go through those. So coronal, exactly the same, okay? So in this case, we've got a coronal from the back. We can see the posterior and the anterior. We can see the meniscus and we can see the meniscal ligaments, okay, from the back. So again, a coronal cross-section through the knee. And we'll be going through those structures as we go. And we've got a axial scan. Okay, and you can see the gastrocnemius muscles in axial location, so that's quite informative for things like that. But yet the axial scan isn't as informative for the structures in the knee, because you take a slice across an axial slice through the knee, you won't be able to get along these structures. Okay, so things like the meniscus, you'll see it in one, maybe two planes, and it may have partial voluming in it. So it's not overly informative. Okay. So gastrocnemius muscle, we can see there, iso-intense, it's a muscle. Okay, so you compare it to the other muscles, you compare it to the fat, and you compare it to the bone. Okay. And you can compare it to the ligaments. Femurs, bicep femoris muscle. So obviously you're gonna have to learn your anatomy. Okay, if you're going to identify these structures, it's important that you learn your anatomy. So you can see the meniscus, so you can see the posterior, we're coming from the back. We've got the fibula there. So this is the lateral side of the knee. Okay, and you can see there's the meniscus. So the meniscus is also very dark. Okay, the only time you'll see signal in the meniscus is if you have a torn meniscus. We also saw, did we have such a lateral? No, we didn't have an axial scan of the meniscus, but the meniscus is very thick at the outside and quite thin in the inside. Okay, or the thick in the periphery. Okay, so we're cutting the posterior ligaments. We've got the tibiofibular joint and the fibula, of course, and the lateral aspect of the knee. Okay, and the structures there. You can see how the posterior cruciate ligament is dark. The anterior cruciate ligament, especially at this location, is not as dark as the posterior. It's made up of little fibers coming through it there. Okay, and that's what the doctors use to when they look at these structures, see whether they're torn or not in a T1 weighted image or a PD weighted image. Okay. Tibial spine, so you can see there, it's not the greatest tibial spine. There's a bit of subchondral damage there. Okay, but you can still see it very well in this anatomic image. Hyaline cartilage. So we know that the cartilage covers the ends of the bones. Okay, there's a couple of different layers. You can see dark, intermediate, and bright layers. Okay, and so that's the different layers in the hyaline cartilage, and then we've got the meniscus. Okay, so we do see different layers in the hyaline cartilage. And then we're coming anterior. So we've got the medial and the lateral horn of the meniscus. Okay. Again, dark. Normal meniscus is dark. And the collateral ligaments, obviously the tibia. So we come to the front. Now we come from lateral. So we've got the tibial collateral ligament. Again, we don't see that very well. If we were doing a sagittal, we wouldn't use the sagittal to assess this ligament because we only get an image alongside it and there's partial voluming involved. Okay. We've got what's called a bow tie appearance. Okay, so, or at least we'll be getting to a bow tie appearance. So that's a nice shot of the lateral meniscus where it's dark. I could imagine a tear, that very faint line going through there. Okay, and now we get to a bow tie appearance. This is a lovely image of the cartilage. You can see the cartilage and the different intensities going along that bony surface. Okay, semimembranosus tendon coming from the semimembranosus muscle, of course. Okay, Anterior, posterior body of the meniscus. Gastrocnemius, so again, we've got the gastrocnemius muscle, and we've got a lovely, it tapers into a lovely tendon that attaches onto the condyle. Okay. And there we have our posterior ligament, so posterior cruciate ligament. So of course we're coming to the midline of the knee. And then we have the anterior. And again, you can see the difference between the two. Okay. Of course, this is the posterior and the anterior are according to the position on the tibia. So the anterior attachment is anterior on the tibial plateau, and the posterior is posterior. Infrapatellar fat pad, patellar tendon, and then, of course, we have the gastrocnemius muscle on the lateral side. Okay, I know it's the lateral side because I'm starting to see the fibula. Tibialis anterior muscle speaks for itself. Quadriceps tendon, so we're starting at the top. We know the iliotibial tract runs all the way down the leg, or a lot of the way down the leg. And there's the tibial nerve, okay? And you can see the difference between the nerve bundles and the arterial vessels, okay? So that's how you differentiate the two, the bundles of nerve tissues and the arterial. Posterior cruciate tibial collateral ligaments. Anterior cruciate. I can read, you see. Shows the lateral from the medial head of the gastrocnemius. Patellar tendon. Of course, the collateral ligaments are at the side of the knee. And we'll be able to see that that's the lateral because there's the fibula. Okay. Vein and artery. You can see how the artery is quite, to differentiate those two is a little bit difficult at this stage, but you can see how the artery is more compact, round, and it's got a muscular wall, whereas the vein is a little bit squashy. Okay, and you know, maybe you've done ultrasound, and you know that when they do ultrasound, they push with their probe on the vessel, and the vein compresses, whereas the artery, its muscular wall, stays quite tight. Okay, so that's a good lesson all the way through the body. The arteries are quite tight, the veins can compress, a little less muscle in their walls. Of course, that's the tibiofibular joint. Okay, so some muscles of the shoulder. You've got a couple of examples there. I'm sure you've got a lot of textbooks, you've got a lot of websites that you can look at. There's some origin insertions. So if you learned those origins and insertions of the shoulder muscles, you'd be able to work out what's what, okay? With a bit of prior knowledge, I should. So we're looking at an axial image of the shoulder. We're coming from superior to inferior, of course. Okay, and now we've got the supraspinatus muscle, okay, and then that comes along, and as we go down, further down the axial image, we'll get into the tendon. Okay, so we'll get the supraspinatus tendon. That's important for us because all these images that you'll see, the coronal and sagittal images, are all perpendicular or orthogonal to that muscle. Okay, so you won't get images that go across this, that are orthogonal to the patient. They're all going to go along that muscle, and you learn that technique in third year and fourth year. Okay, so we've got deltoid. So we've got the lateral, the middle deltoid, anterior and posterior deltoid. Of course, we can see the difference between the muscles, the bone, the cortex of the bone, and maybe the ligaments. Some of the ligaments that we're going to see are dark. Okay. So some of the ones, so coracoid, okay, coracohumeral ligament. Okay, so we obviously know that goes from the coracoid to the humerus. So if you know where the humerus is, you know where the coracoid is, you're going to be able to work out that ligament. Okay. Now the labrum's is important for the shoulder joint because it's an extension of the shoulder joint. Okay, so without the labrum, you can see the little dark labrums here, posterior and anterior labrum. Without those labrums, that shoulder joint is going to sublux. It's going to come out of the glenoid fossa. Okay, that labrum just acts as a little extension to the joint. All right, and again, it's hypo-intense on all images. All right, unless you may be able to see little signals inside that labrum where there's damage to the labrum. So here, there's a little signal inside between the labrum and the glenohumeral joint, which may indicate damage to that labrum. Okay. And then the patient's going to have chronic subluxation of that joint, of that shoulder joint. Infraspinatus, so we know we're underneath the spine of the scapula, okay, which is posterior. So we've got infraspinatus, infra underneath, spinatus, the spine of the scapula, okay, and here we've got subscapularis, so that's underneath the scapula. Okay, so that's anterior, whereas infraspinatus is posterior to the scapula. Okay, and if you can learn that, then you can distinguish those two muscles. All right. So that shows really well the labrum. Okay, the posterior and anterior labrum. Tendon of the subscapularis muscle. So that's our axial. Maybe it would be good to start with the coronal when you're learning these structures. But you've got the trapezius, you've got the infraspinatus. Okay, so we're coming from the posterior to the anterior. You've got the acromion, and of course, as we come along, as we come anterior, we're going to find that joins with the clavicle at the acromioclavicular joint. Of course, you've got the femoral head and the deltoid. So there's the acromioclavicular joint, okay, or capsule, acromion, clavicle, the trapezius and the supraspinatus. Okay, so the supraspinatus, supra on top of the spine. Okay, and you can see how there's the muscle there, and then it extends down to the ligament, or the tendon, the supraspinatus tendon. Okay, or the rotator cuff. Humeral head, greater tuberosity. Okay, so that's attachment for a lot of structures, including the supraspinatus tendon. Okay. Oh my gosh. I will reload these, re-upload these as soon as we've finished. Inferior glenoid labrum, and of course we've got the axillary vein, arteries and nerves. So just like we've got a bundle under here, axillary meaning armpit, and we've got a bundle under here under the arms, okay, that goes through the axilla or the armpit. Okay, supraspinatus tendon, supraspinatus muscle, and then of course you've got the coracoid, you've got the clavicle and the humeral head, you've got the other structures there. Infraspinatus, okay, and so now we're looking at it from the sagittal, okay, so we're looking from outside through the shoulder, okay, and we've got, if we're looking from the lateral aspect, we can see all these tendons, okay, and they're all coming out laterally to insert onto the greater tubercle of the humerus, or thereabouts. And then as we come more medial, we have a very busy slide here that shows you the lateral aspect of these muscles. Okay, so there's the supraspinatus muscle, and there's the tendon there, okay, in the middle. Okay, and then we've got, of course, we've got all the muscles and tendons there. This is quite, we do use all three planes in the shoulder, but certainly when you're learning these structures, make sure you use all these three planes to identify these structures in the different planes. Okay, and I would learn the structures individually so you can see what they look like on the three different planes. And then you get a better idea of exactly where they are in the shoulder. Okay, so again, another slide. Axial shoulder. And then just as a side, we have the hip joint. Again, the labrum in the hip joint. Okay. Coronal hip. Structures in the hip. And then we've got a little quiz here. You can do the quiz. I will post the answers up in a separate little download on Moodle. Okay, so of course, these are the sort of things you need to identify where you are in the knee, so you know, we can see that's the head of the fibula, the joint with the tibia, and we've got the meniscal bow tie appearance of the meniscus. So it's a lateral or a parasagittal slice through the knee. Okay, any questions? Anyone got any questions on what we've covered? Okay. All right. Well, good luck in your test. You know, you can email me or discussion board or anything if you do have any questions. And I will reload these up in about 5 minutes. I'll just do quick changes and reload them up onto Moodle. And I'll stop sharing, and I will stop recording.